என்ன கொடுத்துட்டு போங்க. நீங்க போறீங்களா வீட்டுக்கு? இல்லடா, 140. 140. இங்க என்னன்னா 340 காமிக்கியா, இதுல 240 காமிக்குது. ஏன் சிஸ்டம்? அதனாலதான் நான் பார்த்தேனே. ஏன் சிஸ்டம்? அதனாலதான் நான் பார்த்தேனே.
Hello, madam. Good morning. Good afternoon, madam. Madam, நீங்க first
மட்டும் இப்ப யார் யாரெல்லாம் பிரசன்ட்
madam, Sita madam.
சொல்லுப்பா.
Okay, madam. People are there, madam. We'll
Yeah,
start.
I know, I saw Priya, Abhirami, ஏதோ பேர்லாம் வருது.
All the presenters are here, madam.
சரி சரி, okay. No, because see, கொஞ்சம் youngsters, young postgraduates or young junior pathologists இருந்தா அந்த ஸ்பாட்டை பத்தி கொஞ்சம் சொல்லலாம்னு நினைச்சேன். ஒத்துழைமே காணும்.
And you can see the screen, no ma'am.
வளர்.
Madam, சொல்லுங்க madam.
ஸ்கிரீன் தெரியுதாமா?
நல்லா தெரியுது madam. நல்லா தெரியுது.
Okay.
Ma, please ask. Madam Sandhya madam, good afternoon madam. என்னடே எல்லாரும் ஆன் பண்ணிட்டு you know no we should copy from the I want all the first year.
Good morning, all of you, Dr. Chandra and Dr. Valar.
Sir, good morning sir. How are you sir?
Fine, doctor.
Fine sir. சொல்லுங்க சார், நல்லா இருக்கு. அப்புறம் வேற என்ன விசேஷம் சார்?
கிருஷ்ணகுமார், ஒரு 10-15 ஸ்லைட போட்டு என்னமோ போட்டு வச்சிருக்க.
மேடம் என்ன மேடம் செய்யறது, எங்கிட்ட ஏதோ அதுலயே சில இது டவுட்லாம் இருக்கு. அதனாலதான் வந்து கருத்துக்கள் கேட்கலான்னு இருக்கேன் மேடம்.
சரி சரி சரி, ஓகே ஓகே ஓகே, நைஸ் டு see you after a long time.
Yes madam, yes madam.
ஏன் இந்த பேப்பர் வேஸ்ட் பண்றீங்க?
He wants our diagnosis. For what?
சீதா மேடம் இருக்காங்களா மேடம்? ஹலோ,
சொல்லு.
இதுலயே ஒரு கேஸ் ஐ டோல்ட் டாக்டர் வடர் மேடம், இந்த மாதிரி வந்து ஒரு பேஷண்ட் மேடம், possibly NKT cell lymphoma in the nose and pharyngeal area, age 78, and PET scan all no other lesions elsewhere, and immunohistochemistry at Bangalore, it came as borderline Cori atypical T cell infiltrate port. The slides came here. Multiple herpetic inclusions were seen, madam. I told Dr. Vadaramadi, I was not able to get the slides from my collection.
Yes.
It was herpetic inclusions, so they are treating with the valsector the patient.
Okay.
How herpes infection can mimic odd lymphomas in elderly people? அது நல்ல கேஸ் மேடம். அது
Okay. சரி nice.
Hello Sita madam. Hello madam.
Satya, you are looking
I'm looking
different.
I'm not. So Saturday madam, so I have switched to
Mufti.
Mufti. Exactly, that's the word. I'm in Mufti. People don't recognize you, no? So you can quietly kind of blend with the people.
Nice to see you.
Thank you ma'am, thank you. Nice to see you too.
Madam, you look the same, madam. You look the same after many years.
Krishna Kumar,
yeah. Valar, hello Valar, how are you?
Good afternoon, madam. I was waiting. Good afternoon, madam.
Yeah,
Madam, fine, madam.
Yeah, very nice. Thank you so much for a month on month. You know, it's so nice to have these meets.
This is the 40th meet.
40th meet.
Yeah, good. Very nice.
Maybe Sita
and
madam
all good cases.
Maybe Sita madam
being
can
presented.
Sita madam can sponsor online எல்லாருக்குமே ஒரு பக்கோடா போண்டா அந்த மாதிரி.
No problem, Krishna Kumar. We can all do.
Yeah,
actually,
we can't forget that, madam.
Impana wants to host the next meeting in our hospital. அப்போ உங்களுக்கு நாங்க வந்து பயங்கரமா சாப்பாடு போட்டுறோம். கவலைப்படாத.
Super. Very nice. Thank you, madam.
But Anna, nobody wants it to have, see, practicality is there. It is difficult on a working day. The மாதிரி வரும்பொழுது, luckily it happened to be a 4th Saturday. So, உனக்கு வந்து இது கம்மியா இருக்கு கூட்டம். But ஆனா usually working dayல Saturday is usually heavy everywhere. Saturday and Monday. அது எல்லா வேலையும் விட்டுட்டு 2 மணிக்கெல்லாம் இங்க வந்து எந்த இடத்துல மீட்டிங் நடக்கிறதோ அங்க போகணும்னாக்க practical difficulty in the Zoom is a real boon.
Exactly, madam. But madam, what I was thinking is maybe one meeting in a year we can have offline.
Madam,
50th meeting we will host.
Yeah, in 50th meeting, in preparation itself, we can have it offline.
Okay.
So that mentally we are prepared that this meeting we will all meet.
Okay.
And
அதுல வந்து வேற மாதிரி instead of இது வேற மாதிரி ஏதாவது பண்ண முடியுமா என்னன்னு யோசிங்க.
Madam, இதே மாதிரி ஸ்லைட் செமினார் வச்சுட்டு ஒரு என்டர்டெயின்மெண்ட் ப்ரோக்ராம் அந்த மாதிரி டிஃபரண்ட் டைப் too much of academics, madam.
Yeah, so one dance can be performed by the chief organizer Valarmati.
Yes.
He's a great dancer, you know that?
யாரு?
Madam.
Valarmati.
Madam, நம்ம அப்புறம்
classical and
அது தெரியும். Valarmati. You know that. We'll have academic come entertainment program. That will be nice.
Okay, we'll plan something, definitely.
Madam will, Sita madam will calcify, whatever it is. She'll always, full into madam. Really, so much appreciated. No, that's a good idea, Balan. In the academic come entertainment.
We'll have in the Mari or institute lende case slide seminar. Just for that, and then we'll have one non-academic get-together.
Yes,
Exactly. So academic 35 minutes.
Everywhere.
Yeah, that will be nice. That will be really
academic
nice.
40 minutes, non-academic for longer time. That's it.
And with lunch.
When we are meeting, 50th we should celebrate, no, ma'am. 50th is really a good, excellent endeavor. And
that's a golden jubilee, no?
Golden jubilee. Yes. Amazing.
என்ன ப்ராப்ளம்னா 50 வருஷத்துக்கு இன்னும் 2 வருஷம்
இல்ல 45 கூட செலிப்ரேட் பண்ணிடலாம்.
45 கூட பண்ணலாம். 45 கூட பண்ணலாம் வேலை. இது 40th இல்ல. இன்னும் 5
இயர் கணக்கு நீ மீட்டிங் விட்டுடு. 5வது வருஷம்னா that is a milestone.
மேடம் அப்படி இல்ல. அப்போ வந்து அந்த மழை காலம் அந்த மாதிரிலாம் வந்துருச்சுனா இதுவாயிடும். அதனால இந்த மிட் இயர்லயே ஏதாவது ஒன்னு ஒரு ஆர்கனைஸ் பண்ணி
இல்ல மேடம், இப்போ எத்தனாவது வருஷம் இது ஆரம்பிச்சு? When did you start?
17, madam. 17, madam. 17.
17. Correct. Na sonna. அப்ப 7 வருஷம் ஆச்சா?
ஆமா மேடம். ஆமா மேடம்.
7 years. 7 years we can say that.
1 year 6
ஜமீலா மேடம் ஃபர்ஸ்ட் இத போட்டாங்களே கொஞ்ச நாளைக்கு முன்னாடி போட்டோ போட்டாங்களே.
Oh.
First one MMC இல்ல வளர்.
Madam?
மறந்து போச்சு. First one was in MMC, yeah?
First one was in MMC, madam.
I know because I presented one case appo. Ama, first one was in MMC.
That is
Hello,
even-
madam.
யாரு?
இது நம்ம
கிட்ட வந்தா தெரியும். Yeah, madam. Madam, good morning, madam. Good morning.
good morning. Good morning.
Madam, first city pathology meet was 8 years ago in MMC.
Yes,
Oh.
I remember that.
We also hosted 2 meetings.
Ama, madam, you hosted 2
Yes,
meetings.
yes. Yes. Yes, madam, I also too.
And Krishna Kumar didn't come, otherwise you would have enjoyed that snacks.
I
You
know.
always have snacks. Say,
Madam,
we always
I
have
came to a
snacks.
meeting, madam. I came to one meeting நீங்க ஆர்கனைசர் மேத்தர் வச்சீங்க madam.
Correct. Okay then. Good.
இங்க இல்ல இப்போ.
Okay, Maniacha, can we start?
Yes,
Yeah, I
ma'am.
think we can start.
Yeah.
So
Okay. Unmute.
welcoming all of you for the 40th city pathology meet. Wouldn't have been possible without all the enthusiasm of all the participants, madam. And thank you, madam. And madam, you can start your.
Yeah. Dr. Impana is the one who is presenting the case.
Welcome, Dr. Impana.
Thank you, ma'am. Good afternoon, everyone, and welcome to the 40th city pathology meet. So I'll be presenting 2 cases, and in the end there is one spotter. Coming to the first case, it is a 5-year female who came to the emergency room with intermittent fever, decreased intake and tiredness. On examination, dengue IgM was positive. Chest X-ray showed complete opacification of the left lung with minimal sparing of apex. Consolidation was suspected, so CT was suggested. On sagittal and oblique view of the CT, there was a well-defined heterogeneous mass. The focus was in mediastinum, which involved bilateral thorax. Left was involved more than right. And there were streaks of fat in this well-defined lesion in the anterior mediastinum. So grossly, we received multiple pale yellow to hemorrhagic fatty tissue measuring around 25 into 15 centimeter, and it weighed around 1.1 kg. So this lesion was removed by thoracoscopic excision, and then peritumoral adhesion was there. And finally, when they saw through the thoracoscope, all the lesion, whole of it was removed. So on microscopy, what we saw was thymic tissue and hyperplastic adipocytic tissue. So the thymic tissue had both cortex and medulla with calcified Hassel's corpuscle. And also adipocytes you can see with well-differentiated cells, and there were no lipoblasts or no abnormal cells. So finally, we gave a diagnosis of thymolipoma. So thymolipoma was suggested initially in 1949 by Hall. He called it as a mixed tumor because it comprised both fat and thymic tissue. There is no age restriction or sex predilection. It can occur at any age. It comprises 2 to 9% of all thymic neoplasms. They are mostly asymptomatic or might be associated with some pressure-related symptoms. Some patients may have symptoms associated with paraneoplastic syndrome such as myasthenia gravis or Graves' disease or hypogammaglobulinemia. In our case, all the tumor markers were negative and there were no associated paraneoplastic syndromes. It is classified in WHO under thoracic tumors under the mesenchymal tumors heading in 5th edition of WHO. Although many case series are there and reports are there, the origin still is not sure of a thymolipoma. There are many theories on the origin. First is the neoplastic theory, which calls it as a pure mesenchymal origin, that is lipoma of thymic fat, or a mixed endodermal and the mesenchymal tumor. To support this theory, there was an article published by Mikeva et al. In his case, they found out that there was increase in the levels of CA19-9. So this was thought to be due to the neoplastic thymic tissue, because once the lesion was removed, the levels came down to normal. So this theory was supported by this paper. So the second theory states it as a hematomatous lesion. And third is the regression category, which is thought to be a regression, that is fatty replacement of the thymic hyperplasia, or also a regress thymoma is also a possibility. So these are the three theories which are considered for the origin of thymolipoma. So this case, finally we gave it as a thymolipoma. It's a benign tumor. So differential diagnosis you can think as a lipoma, hematoma, or sometimes in some cases of thymolipoma, even a neuroendocrine tumor or a thymoma may be seen in inside the thymolipoma. So we gave extensive sections and there was no tumor associated with this lesion. So finally the diagnosis was just a thymolipoma.
Any comments about this case? This case was mainly due to the rarity. See, the whole incidence is actually less than 10%. Only 2 to 9%. The entire population is a thymolipoma, and it was a giant thymolipoma, 1.5 kg weighing, and surprisingly, the child never had any symptoms of pressure. The child came only for dengue fever, and incidentally, when the chest X-ray was taken, this was detected. In spite of the heavy weight and giant size, the child did not have much of compression symptoms. That was a real surprise for all of us. And clinically also, you can have a paraneoplastic syndrome, and dengue fever cannot be considered as a paraneoplastic syndrome. So some of the literature says that lymphocytosis in a child can be associated with thymolipoma. So the moral of the story is any child or anybody coming with mediastinal mass, especially in the anterior mediastinum, one of the differential diagnosis should include a thymolipoma. That is the main reason it was presented, because of the rarity and the very asymptomatic presentation despite the giant size and the weight. So that is the main reason we presented this case. Sandhya, have you come across thymolipoma anywhere?
Yes, madam. I was just going to say, we recently, just 2 weeks back, we had a thymolipoma, but not this big. It was a medium-sized one, but behind that, there was a thymoma also. So the thymolipoma, I mean, 2 masses are amchanga, sir, madam. One was a naive, well-circumscribed thymolipoma, and behind that, we also had a B2, B1 thymoma. So sometimes, they may, I mean, obviously, yours was very classically full of fat and all of that. But there was a thymoma behind, madam. I wanted to know whether radiologically can they make out, madam, by any chance?
Yeah, they made it. They made the diagnosis.
The fat was streaks were there, ma'am. In CT only they gave directly as thymolipoma.
Yeah. And like madam said, I don't know how the patient was asymptomatic. That is really amazing.
It's such a small child, never had any symptoms except fever and dengue fever, treated outside. And incidentally, when she came here and we did a X-ray and a CT chest, we picked up that, and it was a difficult surgery also for the thoracic surgeon, because of the huge size and the younger age of the child. So for all this only, in fact, I think I'm practicing almost more than 40 years now. I have never seen, I have never reported even in MMC, we have reported so many thymic tumors.
Yeah, no, this is a rare condition, madam, very rare. Actually,
So thymolipoma I am seeing for the first time. That too, so much well differentiated. It's supposed to be a mature and well differentiated adipocyte tissue admixed with thymic tissue. So very, very classical. The slide was very classical.
Classical, yes. Thank
you. The second case is also a very interesting case. Yes, ma'am.
Coming to the second case, it is a 3-year male who came to the emergency room with fever for 2 days, blood in stools, and the blood-stained vomiting of 1 episode. Clinically, the baby was pale and icteric, and the saturation, even with a non-rebreathable mass, was 85%. And immediately co-oximetry was sent and found to have methemoglobinemia. And we got CBC, for which HP was 5.4, severe anemia was there, RBC count was reduced, WBC count was mildly high increase, that is 26,000, and differential count, predominance of neutrophils, platelets were increased, and methemoglobinemia was there. So when we saw the smear, RBC count is reduced, and you can see anisocoiculocytosis, hypochromic cells, some spherocytes, some some helmet cells also we saw, right? By cells, helmet cells, and mainly, but one nucleated RBC we saw, and as severe anemia was there and increased platelet count and WBC count was also raised, we wanted to rule out any blasts also, but lymphocytes all looked reactive and increased platelet was there. So finally, we gave the diagnosis as severe anemia with marked anisopocytosis and occasional normoblasts, suggestive of a hemolytic picture, and neutrophilic leukocytosis was there with toxic changes. So liver function test was done because patient was sick and found to have increased total bilirubin and also indirect component was increased. So in the ER, they picked up elicited one history, which was important because intravascular, they were suspecting hemolytic anemia because patient was icteric, and when the saturation was not maintaining, in the ER itself, they picked up a history called naphthalene intake history. They found out from the parents. They told 2 days back the baby had naphthalene intake. So when we searched for details about naphthalene poisoning and associated blood picture, we found the same picture which we had. So it showed microcytes, macrocytes, and features of acute intravascular hemolysis. On day 2, the baby picked up very well with exchange transfusion. Here also, for methemoglobinemia, they usually give methylene blue as the treatment. This boy was a 3-year-old boy from North India. So they had G6PD deficiency in the back of the mind, and they didn't want to start methylene blue because it will cause even severe hemolysis. So they withheld that and they started just on exchange transfusion, and G6PD levels were sent and they were awaiting for the report. So this was the second day smear. Normocytic normochromic RBCs closely packed, hemoglobin picked up, RBC count picked up, nucleated RBCs are there, and predominance of neutrophils was there. So when the G6PD report came, it was reduced. So this case we call it is a G6PD deficiency with acquired acute methemoglobinemia, which was secondary to a naphthalene ingestion. So how does this naphthalene poisoning affect individuals with G6PD deficiency? Usually they have increased vulnerability. Individuals with G6PD deficiency are more susceptible to harmful exposure of naphthalene because it causes the oxidative stress and causes intravascular hemolysis. And may also result in organ damage like kidney failure, which may require dialysis. But our patient recovered completely after exchange transfusion with 3 units of PRBC. So the final diagnosis was G6PD deficiency with acute acquired methemoglobinemia, which was secondary to a naphthalene ingestion.
The main reason why we presented was there are a lot of young people here with small children at home. In fact, Impana, who presented this case, was so scared. She leaves the child at home and comes for duty the whole day here. And suddenly the child takes a naphthalene. You know, all household people will use naphthalene balls, right? So, you know, the children, they may not realize the significance or the danger associated with this. So they might put it up thinking it is a chocolate. So that is the main reason. And, you know, the first time, all the pediatricians and the people in ER, immediately they picked up, without even a hint of clue, they picked up naphthalene poisoning. Immediately they phoned up and said it is a case of naphthalene poisoning. We were all taken aback. So, anybody who has come across such kind of a situation of naphthalene poisoning with acquired hemolytic anemia? No? Vale? Your hematology? Yeah, so that is the main reason why we presented this, because awareness should be created about naphthalene association with hemolytic anemia. And so there are a lot of literatures. If you go into the literature search, there are a lot of literatures connecting naphthalene ingestion with hemolytic anemia.
Okay.
And in CPC, when we presented, the pediatricians told that intravascular hemolysis, and when the baby is not maintaining saturation, the first diagnosis of theirs is naphthalene ingestion. So
we presented this case in our clinical pathological conference here with pediatricians. And this was a point which was brought out by them. And immediately, you know, when they did methemoglobinemia, there was also co-oximetry we did for ABG, and you know, methemoglobin was high. So immediately they concluded that it is a case of naphthalene poisoning and immediate exchange transfusion, that was very, very good. See, otherwise probably the child would have been lost. But immediately they tried exchange transfusion, and it was very wise of them to think of G6PD also, because the child came from North India. See, recently we had another gentleman who came here. The people had told him you have got a thalassemia trait. And the hemogram actually looked like that. Low hemoglobin with low all the hemoglobin indices and all that. He was scared because his family had hematological cancer, and so he wanted to know whether he is prone for that. And we didn't have his hemoglobin electrophoresis values. But then we asked him, we took again another sample from him, and we also checked up. It turned out to be a hemoglobin E, because our hematologist suspected hemoglobin E because he comes from West Bengal. So epidemiologically, I think all of us should be aware, because now Madras has become a medical kind of a hub, and we get people from all over India and even from abroad. So that history is very, very important, where they hail from. Because this child is from North India, they suspected G6PD, and it proved very, very useful. So all that is said, that is why they didn't start them on methylene blue, which is very, very important, very valuable point to note. So all this we thought we will definitely discuss in the meeting, so that people will be aware of the association of naphthalene poisoning with methemoglobinemia and acute hemolytic anemia. See, that is acquired hemolytic anemia. That is the main reason why we presented this. Any comments?
Madam, I have one doubt, madam.
Yeah,
Usually, when there is an acute hemolysis, they tell the G6PD levels may be high. So you may be not able to diagnose G6PD in a G6PD deficiency. But how was G6PD deficiency identified in this child, madam?
I think not immediately they sent. I think they sent after second day or third day they sent. After they tide over the crisis. Okay. So maybe hemolytic level would have come down. I don't know. I am not aware of this. But it was there. Definitely it was reduced. There is no doubt about it.
Yes, madam. Yes.
Okay. And shall we go to the next one? I think I am taking too much of time. How many of you diagnosed this condition? We had one single line. A 16-year-old boy with the subcutaneous swelling in the forearm. That is the only history that we had from one of our referral doctors.
It's a sebaceous cyst.
The clinical diagnosis was a sebaceous cyst. And was there any skin? I don't think there was any skin. It was a subcutaneous mass, so they just put a small cleavage, like a small incision, and they removed this. And in the low power, we saw only some black color and pigment and all that. It was not looking like a sebaceous cyst, and this was the high power. Anybody, any wild guess?
Oxalosis, madam.
Ochronosis. You thought of ochronosis?
We have seen.
That's good, because we also thought like that. But then, when we looked into the gross, you see the black thing there, in the gloved hand of Impana. You see a small blackish thing. You know what is that? You will be surprised to learn. It is a pencil core. Pencil or a hook irukalla. That is the one. Then, after we saw this.
Madam, what is it? What did you say?
Pencil or a lead veliyila varumallama. Pencil, eludra pencil. What we write with the pencil. Yes. When you see the pencil lead, pencil or a tip, that that breaks and comes, no? That has gone and pierced him. That history we got. So after I saw this, we phoned up to the consultant. And then we asked him, why did you send it as a sebaceous cyst? We don't find any sebaceous cyst. Then he said, madam, his mother, he's a 16-year-old boy. His mother was telling that he was pricked by a pencil, and after that only the swelling developed, and some trauma was there, some foreign body is there. That is what he told. Then, we searched the literature, and there is an entity called a pencil core granuloma. There are quite a number of articles.
That's not, madam. All history also we only have to find out. That's the thing.
Yeah, that is the main
Nowadays it's
problem,
like that only.
Sandhya. That is the main problem.
That is
See,
the main problem.
otherwise, but the pigment is actually not what the type of a pigment that we find in ochronosis. Ochronosis will have some kind of a brownish color.
Brownish.
This was
Yeah, very
more of
brownish.
black.
Correct.
It was
Yeah.
more of blackish. So we didn't know
Blackish.
whether it was a nevus or
Okay.
blue nevus or whatever it is, because the whole thing was completely started with this, and there was so much of foreign body reaction. So we know it is a
Yeah.
foreign body, and then we searched the literature, and this is a pencil core granuloma which has been reported even in very elderly people where they have been pricked by a pencil 16 years ago, 20 years ago, because the
Oh.
granulomatous lesion develops very long. And this is an article which I have quoted, and
Okay.
she remembered injured with a pencil tip around 60 years back. Can you imagine?
I can
60
imagine.
years back when she was 7 years old. So that is what I'm saying. This is pencil tip going, and it is actually, if you analyze the composition, it is a graphite, which is composed of graphite, clay, and wax. Now
Yes,
the problem is, the accidents usually caused by this material in the childhood, but granuloma secondary to retained pencil are rarely reported in the literature, and it takes a longer time because of it has to be dissolved, and then the core graphite has to be exposed. After
Okay.
it is after all this clay and wax all get dissolved over the period of time, it gets exposed and excites a foreign body reaction and a small granulomatous focus. So that is the main reason.
Madam, we are still learning. You are still my teacher, madam. You've been teaching us all along, and still we are learning from you, madam. Thank you, madam. Thank you. Really,
this was very,
truly.
very surprising. And we never leave any chance. We always bother the clinician. Unless we get a proper history, we never report. See, that is what I'm saying. I keep on insisting that history taking is so very important for every case to be reported. Even that naphthalene poisoning, though we suspected, they confirmed, the parents confirmed that the child assumed. They never told us initially. See, that's what I'm saying. You have to literally dig out the history if you want to properly report. This was a real eye-opener for us. Because we all use pencil, no? And pencil tip also breaks. And supposing incidentally it goes into your subcutaneous tissue, you never know. After 60 years, you may come out with a swelling there. So that is the main reason we presented this.
Ma'am, how did they get this? How did they make it? Graphite, clay, and all?
No, that is part of the pencil core. The pencil lead that is made up of this. You go and see what is the composition of a pencil core. That is what it is made up of.
Graphite.
Yeah, so it got broken and it entered his body.
It's so surprising. நிறைய குழந்தைங்க வாயில வச்சு கடிக்கும். ஆனா இது changes.
When they fight with each other also, they can prick with the pencil lid and it may inadvertently may enter the body. That is also there.
Very nice, Sita.
So we thought we will present all these cases. Okay, thank you.
Thank you, madam.
அவ்வளவுதானா? Surprises அவ்வளவுதானா?
Okay, madam. Thank you so much, madam. Thank you for the surprises. Thank you, Dr. Impana. Thank you, madam. Sita Lakshmi, madam. Sir Krishna Kumar, sir, can you share your screen, sir?
Madam, are you able to see the slides, madam?
Yes, sir.
Okay, madam. Good afternoon, all of you. The first case, this patient was in Gulf for 5 years. He had a plaque on the face. 15 years the plaque is there, and so people had put on many treatment, not responded. So biopsy was done, and biopsy, what we see is this is the facial plaque, erythematous plaque on the face. We find an hyperplastic epidermis and multiple giant cells are seen in the dermis. Multinucleate cells, lymphocytes, plasma cells. A lot of plasma cells are there. So once again, giant cells. So either fungus is negative, quantiferon gold negative, LD serology that at lal path lab was negative, serology negative. At this stage, we don't have a diagnosis. Patient is responding to itraconazole. Now he has completed 4 weeks. It is not IgG4 disease because earlier we have seen IgG4 disease in the skin. We don't see multinucleated cells in IgG4 disease. So we are at this stage waiting for the follow-up after 4 weeks. Then we will take a call. It does not look like rosacea. Majokis granuloma, we seen only in the leg and you see fungal filaments and eosinophils. So at this stage, we don't have a diagnosis. Could it be a plasma cell granuloma? We don't know. So I just want to know what does senior people tell about this case. Going to the second case, this was a person from London who had erythromelalgia. And when he came to Chennai, he consulted my friend Dr. Murugsundaram. See these plaques, this erythematous plaques in the dorsum of the hand. So Dr. Murugsundaram did a biopsy. And what we see here is we find epidermis and dermis. We find perivascular and periacrine lymphocytic infiltrate. So this is something very interesting. When we see this pattern, we have to think in terms of chilblains, pernio. ANA and dsDNA were negative. So we put it as an idiopathic pernio. We don't see this in our country because of the extreme temperature. But this, I understand, is quite common in London. But they have to look for other causes of erythromelalgia, like hematological abnormalities and etc. So this case, we signed out as idiopathic pernio since ANA and dsDNA are negative. Third case from Arvind Eye Foundation biopsy. This is a lady with multiple papules around the lids. And then after the diagnosis, I asked for oral photograph. She also had a tongue which was very much thickened and not able to swallow. And biopsy are done and you find epidermis and pinkish material in the dermis which was cracking. With this pattern, there is only one possibility of lipoid prognosis. Histopathological other differential diagnoses are erythropoietic protoporphyria and amyloid. But the clinical features are not fitting with amyloid and erythropoietic protoporphyria. So this is the case of lipoid prognosis, which is very rare, but we see in ophthalmic practice. This case is a lady, staff nurse with pigmentation on the scalp with loss of hair, alopecia. So biopsy was done. And the dilemma was whether it is lichen planus or discoid lupus erythematosus. Biopsy, you find interface changes with a dense lymphocytic infiltrate with pigment incontinence, and also to show the apoptotic bodies in the dermis. So this was a case of lichen planopilaris with the scarring alopecia. Next is the lady from Texas with the loss of hair and looks like a pattern alopecia, something like that from the clinical photographs. And this is the horizontal sections. Horizontal section, I have marked all these yellow arrows and black arrows. Shows this is the hair follicle units. We see around 7 hair follicle units, hair follicle with the sebaceous glands. We see around 3, 4, 5, 6, 7, 8, around 9 to 10 hair follicle units are seen. In Caucasian, we see around 24 hair follicle units. What is interesting is all these yellow arrows and black arrows indicates follicle miniaturization. The hair follicles are miniaturized. That's the reason for that thinness of the scalp. And in many of the areas, the sebaceous glands are seen. But in some areas, the sebaceous glands are atrophic. And you see some amount of fibrosis, which is slowly developing. Another image shows the sebaceous hair follicle units. And you find the follicular miniaturization. And you find the sebaceous glands are atrophied in some of the pilosebaceous structures. So this is definitely a female pattern alopecia or androgenic alopecia. The only concern is will she respond? Good. The moment the fibrosis develops or the sebaceous glands are atrophic, the prognosis is not so great. So even male pattern alopecia, female pattern alopecia, if you get fibrosis or loss of sebaceous glands, it indicates not a good prognosis. So horizontal sections we routinely do at Shankar Nethralaya. I also report horizontal sections. This is very helpful to give a ratio of anagen telogen hair with terminal hair to comment on perifollicular fibrosis, inflammation. But we also need to have a vertical section so we always compare both vertical sections and horizontal sections. Like people, when they do hair transplant for androgenetic alopecia, they send samples to tell whether the transplant will be successful or not. In this way, horizontal sections are very, very useful. We usually recommend the 4 millimeter punch horizontal sections. Next is from Kolkata, we had a lid ulcer. So they thought of a malignancy and biopsy was done. Biopsy, we find once again a lichenoid interface change. Lichenoid interface change with a no basal membrane thickening. And once again, like the previous case, this is lichen planus. The only thing is, we also find perifollicular infiltrate and perineural infiltrate. So the dilemma is isolated lichen planus in the lid I have never seen. So the dilemma was whether to give it as discoid lupus / lichen planus. But in discoid lupus, usually we see thickening of the basal membrane. No, you ask me, does it matter a lot? Yes, because if it's a plain discoid lupus erythematosus, they will respond very well to hydroxychloroquine oral tablet. Within 2 to 3 months of therapy, the anti-lesions will disappear away. But if this is going to be a lichen planus, then we need to have topical cyclosporin and other things, which is a bit difficult to treat, but challenges are there. So we are waiting for the follow-up from Kolkata. And this is once again another case of alopecia. This man had multiple armpits, multiple boils, and cystic in the face and axilla, florid acne and axillary lesions. And he had this funny looking scarring lesion with the boggy swellings in the scalp. He was put on multiple antibiotics, not much responsive. You see the entire hair is lost here. It was brain or gairai mari. So biopsy was done. Biopsy, what we find is there is a lot of inflammation and giant cells you can see at this stage. And surprisingly, you can see pilosebaceous structures with the sebaceous glands intact. So once again, sebaceous glands are intact here. This is the beauty of this case. This is a granulomatous inflammation with lymphocytes and plasma cells. But you find sebaceous glands are still in fact. This is once again to show granulomatous inflammation. Granuloma. So this is a case of dissecting cellulitis of scalp, which happens with the patients having cystic acne and hydradenitis suppurativa. And one of the important feature in diagnosis is the sebaceous glands are present with inflammation. Like in any other scarring alopecia, the sebaceous glands are very sensitive. They are the first to go. But in dissecting cellulitis, the sebaceous glands goes away. Hello? Sorry. Next is thysically eviscerated. Usually they remove thysically for cosmetic purpose. What we saw was something I never was throwing me away. You have multiple vacuolated cells in the choroid. I had never seen like this in the choroid. So my first thing was looking at it. I was wondering whether it is some renal cell carcinoma metastasis or clear cell variant of clear cell nevus, clear cell melanocytic nevus, or clear cell variant of renal cell carcinoma. I was thinking. So we did the idea. To be very frank, I did not know what it was. So we did the immunopanel. Immunopanel, we CD68 negative, CK negative, HMB45 negative, S100 positive. CD68 was done twice. Synaptophysin negative. So then finally the penny dropped. I sent the images to my mentor at Emory. He said do GFAP, and GFAP was positive. Then we signed out it as hemangioblastoma of the choroid. The patient had the Sturge-Weaver syndrome, it seems, on the face. Either they did not tell us before. I was thinking of Sita Lakshmi madam, no, that history is very important. See, unfortunately, when the consultants give us, they ignore a hemangioma of the face. They think, what is the connection between hemangioma in the face and something in the brain or choroid? But if they are told the patient had a Sturge-Weaver syndrome, we will know. So hemangioblastomas need to occur in Sturge-Weaver syndrome. Yeah, that's all I have for today. Thanks a lot. Any comments? I am open for, I think. Hello? People
Sir.
are there?
Sir, yes, sir. Sir, and the dissecting cellulitis thought it was a fungal filament arcumon. What was the criteria to call it a dissecting cellulitis on the case, Mantra?
Madam, see, dissecting cellulitis, if you see the histopathology, it will be something like your hydradenitis suppurativa. Plasma cells, giant cells, lymphocytes.
Triad மாதிரி இருக்கும்.
Madam?
Triad. conglobate அந்த இது
Yes, 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 madam. அந்த மாதிரி இருக்கும். ரெண்டாவது வந்து my dilemma was whether it is folliculitis decalvans. In folliculitis decalvans, we'll find a lot of neutrophils. In folliculitis decalvans, we find a lot of neutrophils, madam. Inga neutrophils illa, only granulomas there. And in dissecting cellulitis, the sebaceous gland intact. That's what I was very surprised to see. அது வந்து இருக்குமா, island மாதிரி இருக்குமா. That's the last go. So other base செஞ்சு I told it is dissecting cellulitis of scan. And the first case தான் still I am stuck, madam. First case தான் we know it is giant cells and plasma cells. We are waiting for the follow-up. So
mucous membrane plasmacytosis can occur. Oral cavity we have seen reactive plasmacytosis.
So that's what I said. You 4 வாரம் கழிச்சு வரட்டும். We'll do immunohistochemistry to show, make sure it is kappa and lambda. But giants face இந்த மாதிரி 15 years இருக்காது. இந்த மாதிரி we have not seen on the face.
அப்புறம் அந்த லைப்பாய்ட் புரோட்டீனோசிஸ்க்கு தான் நம்ம தம்பியா சார் சொல்ல உல்ஃப் லைக் ஃபேஸ் சொல்றது இதுக்கா?
அது பார்ஃபைரியா. அது பார்ஃபைரியா. அது வந்து பார்ஃபைரி, டர்க்கிஷ் பார்ஃபைரியா தான் மேடம். உல்ஃப் லைக் அந்த டர்க்கிஷ் பார்ஃபைரியா when they consume that hexachlorobenzene which was treated for wheat and ஆப்பிரிக்கால அந்த சாப்பிட்டதுனால வந்து they had this hair on the face. That is Turkish porphyria, madam.
இது எனக்கு லைப்பாய்ட் புரோட்டீனோசிஸ் ஒரு கேஸ் அவர் சார் இருந்த போது நம்ம ரிப்போர்ட் பண்ணினோம். தம்மையா சார்
அவர் நிறைய காமிச்சிருக்காரு. கேஜி ஹாஸ்பிட்டல் தான் வடா சாப்பிட்டு நாங்க எல்லாரும் பாத்துருக்கோம்.
பயங்கர கேசஸ் கேக்கே சூப்பர். எங்கயோ போயிட்டாரு
மேடம். வந்தது மேடம். சரி, எனக்கு வந்து இந்த மாதிரி எல்லாம் இந்த மந்த் வந்ததா முடிச்சாச்சுன்னா நான் அடுத்த மந்த் கேசஸ் கேம்பேன், அவ்வளவுதான். அதனாலதான் மேடம் காமிச்சேன் எல்லாத்தையும்.
நீங்க கொஞ்சம் மிச்சம் வச்சுக்கோங்க, ஒரு மாசத்துக்கு எல்லாம் ஒரே நேரத்துல போட.
இல்ல மேடம், இது வந்து இந்த மாசத்துலயே 1-2 கேஸ் வந்திருக்கு. நான் அதை காமிக்கல. Patient having ulcer in the nose and the palate, diagnosed as atypical T-cell infiltrate. PET scan know the lesion, and so the slide came from Bangalore. It was a herpetic inclusions were giant cells were seen. It was a herpes. Then I told them to put on valsiclovir. They started that. They feel the patient is doing well. So அதெல்லாம் என்னால லோட் சைட் டைமே இல்லாம போயிடுச்சு. I told வளர் அதையும் நான் காமிக்கிறேன். நெக்ஸ்ட் வீக் I'll show that madam in the follow up. அது காமிக்கிறேன்.
Sir, the lipoid proteinosis வந்து it is PAS positive இல்ல சார்? அதோ
மேடம் it is PAS positive மேடம் இருக்கும். ஆமா, பட் வந்து மேடம்
iron globules will be positive all over the body வரும். அது
ஆமா, இது டங்ல இருக்கும், ஸ்கின்லயும் இருக்கும், இன்டரேஷன் இருக்கும் வரும். ஆமா, இது வந்து நமக்கு வரும். இது வந்து அந்த 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 பியூர்லி பாப்யூல்ஸ் இந்த லிட் இஸ் வெரி டயக்னாஸ்டிக் டாக்டர். அந்த ஹிஸ்டரி இல்லாட்டினா நம்ம வந்து புரோட்டோபார்ஃபரியாவா அமைலாடா அந்த மாதிரி தான் தர முடியும். பட் ஒன்ஸ் தே டெல் பியூர்லி பாப்யூல்ஸ் இந்த லிட், ஹோர்ஸ்னஸ் ஆஃப் வாய்ஸ்னா டக்குன்னு வந்து இட் இஸ் லைபாய்ட் புரோட்டீனோசிஸ் அடிச்சிடலாம் நம்ம.
ஓகே, so it's more clinical
disorder
madam.
Very rare disorder.
ஆமா மேடம், பட் மேடம் அரவிந்த் ஹாஸ்பிட்டல், சங்கர் நேத்ரால being referral centers இல்லைங்களா டாக்டர். So I think they get the cases, madam. I do reporting for Arvind Agarwal and Shankar Netralaya. So all the bizarre cases land up in these places. So vandadna we do and make help them in diagnosis, madam.
Thank you.
Thank you, madam.
Thank you, sir. Thank you, sir,
Thank
for
you.
the host of interesting cases. Thank you so much, sir. So can we call ESI Medical College to present Dr. Vanilla?
Okay, ma'am. Okay, ma'am.
Vanilla, share your screen.
போதைப் பொருட்கள் விற்பனையை கட்டுப்படுத்துவதில் உறுதியாக இருந்தார். அவரது
Ma'am, is my screen visible, ma'am?
Yeah, no, your screen is not visible.
Now, ma'am?
Yes, ma. Yes, your screen is visible.
Okay. A very pleasant good afternoon to one and all those who have gathered here. I, Dr. Vanilla Krishnakumar, Senior Resident from Department of Pathology, ESIC Medical College, here to present a case titled Carcinoma and its Metastasis, Unveiling the Pathologist's Vital Role. So it is a 50-year-old female.
Excuse me, you can go to the slide share mode, ma.
Ma'am, it is in the slide share mode, ma'am.
Slideshow.
Now, ma'am?
No, ma.
Please put this slideshow option.
Now, ma'am?
No, ma'am.
No, Dr. Vanilla.
Yes.
No. No.
Now, ma'am?
Yeah, yes. Yes, Dr. Vanilla, continue. Proceed.
A 50 years old female visited a private clinic with complaints of fever on and off and spotting for a month. On examination, the treating physician found a 2 into 2 centimeter apical heart swelling in the left axilla. On examination of the breast was normal. She was treated with antibiotic and the swelling did not subside and she was referred to our hospital. So in our hospital, we did ultrasound where a multiple enlarged hypoechoic lesion in the left axilla was noted, largest measuring 3.3 into 2.7 centimeter with mild internal vascularity, and there was no obvious lesion in both the breasts. So this was the FNAC where we can see the clusters of atypical cells and few lymphocytes. In view of atypical cells, the surgeon proceeded with the further investigation of mammogram. So in mammogram, there was a diffuse dermal thickening in the left breast and there was also left axillary lymphadenopathy. And along with this, they also did the PET scan. In PET scan, there was an increase in the uptake in the, this is the left axilla showing lymph node, increased uptake in the lymph node. And this is the stomach showing the increase in the uptake. And along with this, there was also increase in the uptake in the posterior aspect of the left, inferior aspect of the left scapula. Along with this, there was also increase in the uptake in the jejunum. So with all this, the radiology impression was lymphoma involving the stomach, jejunum, lymph nodes, and also the left breast. And they also gave a possibility of a granulomatous lesion. So then we received a biopsy from the antrum, UGI scope biopsy from the antrum, where grossly we received multiple gray white soft tissue fragments together measuring 1 into 0.5 into 0.2 centimeter. So this was the histopathology where we can see the islands of gastric mucosa, and along with that we also have the one fragment where the entire fragment is composed of sheets of atypical cells which had a moderate eosinophilic cytoplasm along with pleomorphic hyperchromatic nuclei, and also few cells showing prominent nucleoli, and there was also mitotic figure. So we proceeded with IHC. Since the clinician clinically diagnosed as lymphoma, we proceeded with CD45, which came out to be negative, chromogranin, which was also negative, and since we had a doubt of epithelial tumor, we proceeded with pan-CK, which came out to be positive. Then we concluded the slide as a poorly differentiated carcinoma. By the time we also received another biopsy from the same patient, but from the different department, like the patient was referred to oncology, and from there we received a biopsy from the latissimus dorsi. So grossly, it was multiple gray-white linear codes of soft tissue ranging in length from 0.2 to 1.5 centimeter. So here we can see the skeletal muscle. The skeletal muscle is entirely infiltrated by the tumor cells, which is in sheets, and it showed the similar morphology of the previous biopsy. So we again proceeded with IHC markers. Same CD45 came out to be negative, pan-CK came out to be negative, and this is this is actually GATA. Sorry, it is a mistake. It is GATA3, which is positive. So since the patient was 50 years old, female, and there is an axillary lymphadenopathy, we proceeded with GATA3 and it came out to be positive. So we again did the GATA3 in the previous biopsy where it came out to be positive in UJ biopsy of antrum also. So this is a comparison image of the biopsy from the stomach and also the biopsy from the latissimus dorsi, which showed a similar morphology. CD45 was negative in both the cases. pan-CK was positive in both the cases, and GATA3 was also positive in both the cases. Finally, the impression was made as metastatic breast carcinomatous deposit in the stomach and also latissimus dorsi. This is the entire sequence happened here in this case. where in April 12th the patient came with the complaints, and we did the FNAC of the axillary lymph node on 13th of May. So following that, on 21st of May we received a mammo and PET. I mean, they did the mammo and PET CT, but they did not provide us with the report, and we received the antral biopsy on 28th of May, and we proceeded with the IHC. By the time on 3rd of June, we also received the biopsy from latissimus dorsi muscle, and IHC was proceeded. This IHC, along with this IHC, we also did an GATA3 for the antral biopsy. And out of our interest, we got the patient to examine the lump, to examine the breast. So in the breast, we saw a lump in the retroareolar region, which was 3 centimeter. Nipple retraction was seen, dermal edema was seen, and left axilla showed multiple lymph nodes, largest measuring 6 centimeter. So we did an FNAC from the breast where it showed clusters of atypical cells, and there was also multiple tumor giant cells which were seen. So this is a case where carcinoma of breast which get metastasized to the multiple sites like stomach and latissimus dorsi. So breast carcinoma, we can see the metastasis most commonly to the lymph node, bone, liver, lung, and brain. So breast cancer with stomach metastasis is very rare, with the incidence of less than 1%. In one of the studies, it showed that the incidence was less than 0.04%. Usually, the metastasis occurs after years of diagnosis of the primary breast carcinoma. The clinical symptoms in the patients with gastric metastasis are usually atypical, and the most of the patients will be asymptomatic. These are the studies where case reports where the breast carcinoma got metastasized into the stomach, which mimicked as a primary gastric carcinoma, and most of the cases they resembled as a primary gastric carcinoma, but it came out to be a metastasis from the breast carcinoma. So although likewise a direct invasion of the breast carcinoma to the pectoralis major is very common, but metastases to the other muscles are very rare. It only accounts for a very small percentage of cancer, and this is found only in the autopsy. Muscle metastases often remain asymptomatic, and they do not give any physical signs. The prognosis of the patient with the muscle metastasis is poor, and most of the patient die within few months despite of the aggressive treatment. So these are the case reports where we can see the breast carcinoma metastasized to the sternocleidomastoid and also to the bicep muscles. In our case, it got metastasized to latissimus dorsi. So this case is discussed for its rare presentation of metastasis of the breast. Cancer patients present with any abnormal swelling elsewhere in the body must be thoroughly evaluated, and we should always rule out the metastasis. So a proper clinical examination, proper radiological finding, and a proper pathological finding will lead to a early detection and accurate diagnosis of the patient. So these are my references, and thank you.
Excellent presentation. I'm Chandra. Hope I'm audible. Can I make a comment here?
Ma'am, yes, ma'am. Ma'am?
I'm audible.
Ma'am, no, ma'am. No, ma'am. Ma'am, you're not audible, ma'am.
Okay, I will take it. Not a problem. I will take the unit for the kind of answer.
Okay, ma'am.
Okay, ma'am.
Dr. Vanilla, that was a nice case. Any questions? How long was the period from the breast lesion to the metastasis, ma?
Ma'am, actually, the patient came with a metastasis, ma'am. There were no uptake in the PET CT. PET CT also they gave like there was little uptake in left breast, but clinical examination was there was no obvious lesion, ma'am. And in mammo also they gave only dermal thickening and there was no obvious lesion, ma'am. So after all these only we called the patient and we examined and we did FNAC on our interest only, ma'am.
அதுக்கு முன்னாடி clinicians examine பண்ணலையாமா?
Examine பண்ணியும்
even the mammogram didn't show any lesion, ma'am, any obvious lesion. அது rapidly growing இருக்குதுன்னு நினைக்கிறேன். So mammogramல வந்து there was no lesion, but இந்த FNAC எடுக்கிற இந்த one and a half monthsல வந்து retroareolar lesionல 3 centimeter sizeக்கு it has grown. அதே மாதிரி ஆக்சிலால வந்து initially it was 2 into 2 centimeters, இப்போ பார்க்கும்போது 6 centimeter இருக்குது.
Okay. Now what happened to the breast lesion? Was the hormone mark, ERPR and all, what happened to that?
Ma'am, அதுதான் மேம் அந்த breast we got biopsy from stomach as well as from the latissimus dorsi. FNAC தான் நாங்க பண்ணிருக்கோம், அதனால வந்து ERPR நாங்க பண்ணல மேம். இதுல இனிமேல் பண்ணி பார்க்கலாம்னு.
No, what happened? Whether they did mastectomy or what they will do, they'll just give a palliative therapy. I just wanted to know.
Yes, ma'am. I will update, ma'am. But mostly it is chemotherapy தான் மேம் இருக்கும்.
If there are no questions, any other questions, please?
Axillary node presentation வரச்சவே we have to think of breast first and என்னோட ஐடியா வந்தது.
Yes, ma'am, but clinical examination was clean, ma'am, and ultrasound also did not show any obvious lesion, and mammo also didn't show any obvious lesion, ma'am.
Okay. No, that and one more thing, the stomach pattern also, that infiltrating type also was in my mind when you focus the slide. So, right, good case, ma.
Madam, I just want to share this is a comment from the Chandra madam. She's not connectable, so she has just sent a message. She has said gastric she has seen gastric metastasis and deltoid metastasis from a known case of CA breast. That was 4 years later.
இவங்களுக்கு poly differentiated carcinoma வந்திருக்கு. They're not audible, Vanilla.
Ma'am, yes, ma'am.
இல்ல, what are you said just now? Poly differentiated carcinoma.
No, ma'am. Actually, first antral biopsy, they thought it was lymphoma, and we diagnosed as poorly differentiated carcinoma since we were not sure about the primary, ma'am. Then we received the latissimus dorsi. Then it was a 50 years old female patient with axillary lymph node. We put GATA3 and GATA3 came out to be positive, ma'am.
Yeah, correct approach, ma'am. That's the way we have to do it.
Thank you, ma'am.
Good, very nice. I also thought in the same way only.
Thank you, madam. Thank you, Dr. Vanilla, and thank you, Dr. Meenakshi.
Thank you, ma'am. Thank you, ma'am.
And so we go on to the next case from Stanley Medical College. Dr. Priyadashni is presenting.
Good afternoon, everyone present here. I thank our HOD ma'am, Dr. Ali Sumitra ma'am, and our professor ma'am, Dr. Valarmadi ma'am, for giving me this opportunity to present in this meet. So this is my first presentation in this meet, and I'm thankful to everyone here. So my case is 36 years old male who has been evaluated at CMC for recurrent hypoglycemia for 4 years. He had a history of dizziness and unconsciousness. For he had similar complaints after decreased oral intake and longer duration of fasting. He got resolved after oral intake. So because of this, he has to take multiple frequent meals to avoid the symptoms. So he's a known case of HBV infection, HBV positive. And he has no addictions and no known comorbidities. And he has been diagnosed as superior parathyroid adenoma on imaging. And his family history has his elder sister had history of renal calculi and died due to renal dysfunction at the age of 40. One second. At the age of 35 years. And his elder sister has had nasal tumor, and she also expired at the age of 45 years. And his elder brother expired at the age of 40 years due to recurrent pain abdomen. And his father also had some abdominal tumor at the age of 40 years. And the surgery was done, and he was stable for 10 years and expired at the age of 55. So his paternal uncle also had pancreas tumor and surgery was done and he is stable now. And one of his paternal cousin had pancreas tumor and he is stable post surgery. So this is his family history. This is we have received the Whipple's procedure.
Excuse me, may I request the people, the others, to mute their
So we received Whipple's procedure and lesion from the liver also has been excised. So this is a head of pancreas lesion. On cut surface, we had a gray white circumscribed area which is measuring around 1 centimeter in diameter. So this is a microscopy of this lesion from the head of pancreas showed a pancreatic acini with the tumor arranged in organoid pattern, cords and trabeculae, and the individual tumor cells were round to oval with moderate eosinophilic cytoplasm and the monomorphic nucleus with stippled chromatin. And this is a tail of pancreas also had showed a tumor, well circumscribed gray white tumor, which is measuring around 1 centimeter in diameter. And this microscopy also showed the similar features of the same head of pancreas lesion. So we also his duodenum also had some nodules and multiple nodules, which was measuring around 1 centimeter in diameter. And the microscopy of the duodenum showed a Brunner's gland with a circumscribed tumor with the same pattern of arrangement and the same morphology of cells. And we had the patient also had a stomach thickening, and the microscopy of the stomach thickened area also showed the same pattern of arrangement. And the liver, the metastasis also has been occurred in the liver. So we have received a liver tissue also, which also showed normal liver parenchyma with a tumor, adjacent tumor arranged in a organoid pattern. Also, it also showed the similar features of head of pancreas and the tail of pancreas. So all the organs showed the same morphology. And we did IHC in pancreas. Synaptophysin was positive and Ki67 was 5%. So with this, we have given an impression of neuroendocrine tumor, well differentiated grade 2 with a staging of T4 and N0 and M1A. So with this case, with this history, patient age, clinical symptoms, with a patient's family history, and the patient also has parathyroid adenoma, and he also had elevated gastrin levels. So we also have diagnosed a pancreatic neuroendocrine tumor with the Whipple's procedure we received, and it has been diagnosed as multiple endocrine neoplasia type 1. So this is a criteria for MEN1. So at least 2 of the primary manifestation of MEN1 syndrome has to be there. One is tumor of parathyroid glands, anterior pituitary gland, and a neuroendocrine component of the gastroenteric pancreatic tissue, or at least one MEN-related syndrome, MEN-related tumor, and a first-degree relative with confirmed MEN1, or the mutation of MEN1 gene has to be there, even if no signs and symptoms of MEN1. So this is the evolution of pancreatic neuroendocrine neoplasm. So in 2010 classification, pancreatic neuroendocrine tumor has been classified as well-differentiated neuroendocrine tumor and poorly differentiated neuroendocrine carcinoma based on the proliferation index. That is Ki67 more than 20% and mitotic index more than 20%, 20 per 10 hyperfield has been classified directly into poorly differentiated carcinoma, neuroendocrine carcinoma. But in 2017-19 classification, based on the proliferation index and the differentiation grade, it has been classified into neuroendocrine tumor grade 3. Even if Ki67 index is more than 20% and mitotic index is more than 20 per 10 hyperfield, some patient had some better prognosis. So they have been classified as neuroendocrine tumor grade 3 and poorly differentiated neuroendocrine carcinoma. So this is a WHO classification of pancreatic neuroendocrine neoplasm. Well-differentiated pancreatic neuroendocrine tumor has been classified as functioning and non-functioning tumors. And functioning tumors, insulinoma and gastrinoma are most common, and they are present in the earliest stages because they produce hormones and they produce clinical syndromes, and they have a good prognosis. But the non-functioning tumors, they are present at the later stages with a mass effect. And these are the syndromes associated with the pancreatic neuroendocrine tumors. They constitute around 10%, and most common is the MEN1 syndrome. Next, so all the pancreatic neuroendocrine neoplasms are classified as well-differentiated. All the grade 1, 2, and 3 always present as well-differentiated pancreatic neuroendocrine tumors. And the the poorly differentiated pancreatic neuroendocrine carcinoma, they are classified into two types, small cell type and the large cell type. And mixed neuroendocrine, non-endocrine neoplasm, they can either present as well-differentiated or poorly differentiated neuroendocrine tumors. So this is a pancreatic, well-differentiated neuroendocrine tumor. They have a well-differentiated pattern, and the individual cells have a abundant eosinophilic cytoplasm, and they have a monomorphic nucleus with stippled chromatin. But the poorly differentiated neuroendocrine carcinoma, they have atypical nucleus with some necrosis, and they have abundant mitosis. So these are the differences, and these are the hereditary syndromes associated with the pancreatic neuroendocrine tumors. So the pathogenesis, MEN1 is the most common pathogenesis here. MEN1 mutation is most common. ATRX and DAXS mutation also occurs in this pancreatic neuroendocrine tumors. But in pancreatic neuroendocrine carcinoma, P53 and RB1 mutation is most common. So according to immunohistochemistry, the ATRX and DAX will be lost in 45% of cases in pancreatic neuroendocrine tumor grade 3, and there will be no loss. P53 and RB1 will be lost in pancreatic neuroendocrine carcinoma, and this SMAT will be no loss in pancreatic neuroendocrine tumor grade 3. So these are the differences with which we can differentiate pancreatic neuroendocrine tumor grade 3 and neuroendocrine carcinoma according to immunohistochemistry. So these are my reference article. Thank you. Any comments, ma'am?
Nice presentation and nice case with so much of same morphology. Very nice.
Ma'am, that's a case of men illa madam, multiple organs involved. Adanala.
அதான் ரொம்ப நாள் கழிச்சு இந்த மென்குள்ள வரும்.
We don't get to see it often, ma'am.
ஆமா, பார்த்தது இல்ல. ரொம்ப ஒரு ஓல்டன் டேஸ் தான் அதெல்லாம். இப்ப பார்த்ததே இல்ல. Very nice to bring out to the limelight.
Thank you, ma'am. Then we go on to the next case, ma'am. MNC, Dr. Syed.
Yes, ma'am.
Are you ready?
Yes, ma'am.
Dr. Syed, please share your screen.
Yes, ma'am. Is my screen visible, ma'am?
Continue, ma'am.
This is a 42-year male presented with complaints of abdominal pain and vomiting since 3 months, and he had history of weight loss. In past, he had a surgery of neck swelling in 2018, and family history, father had a history of brain tumor and died at a very young age. So they have gone for routine investigation. CBC showed microcytic hypochromic anemia, and in imaging, ultrasound abdomen showed a mass of size 9.6 plus 8.2 centimeter in the left hypochondrium. So they went for CCT abdomen and pelvis, which showed bilateral adrenal lesions, the possibility of bilateral adrenal adenoma, pheochromocytoma, and granulomatous disease were given. They have gone for special investigation, which showed elevated plasma-free normetanephrine levels. So they thought that is a case of bilateral pheochromocytoma. We received a bilateral adrenalectomy specimen in which the left adrenalectomy specimen was very huge, of size 15 cross 15 cross 5 centimeter, and the cut surface showed a very variegated appearance of tumor with cystic areas and hemorrhage is seen. In microscopy, this is the normal adrenal gland with capsule and tumor interface pheochromocytoma, which is very well encapsulated. This is a low power and high power view where more than 95% of the tumor showed a Zellballen pattern, and intervening stroma is a very rich vascularized stroma has been seen. And one foci showed areas of confluent necrosis also. And these are the areas. These are the areas of hemorrhage. We have added an IHG of carbonic anhydrase 9 and Ki67. CA9 showed positivity in more than 95% of the tumor cells, which is membranous positivity, and Ki67 came out to be 3%. And we have reported it as a bilateral pheochromocytoma with a PAS score of 2 out of 20, and GAP score came 3 out of 10. So with this bilateral adrenal pheochromocytoma and the past history of neck swelling, in 2018, we came out to be the neck swelling as paraganglioma. So we thought of paraganglioma pheochroma related syndromes. And his father also had died at a very young age with a history of brain tumor, and he gave history that tumor to be a blood tumor. So the clinicians thought to be of hemangioblastoma. Coming to the differential diagnosis of adrenal pheochromocytoma, we have adrenal cortical carcinoma, adrenal medullary hyperplasia, metastasis from renal cell carcinoma, melanoma, colon, breast, and lung cancers, adrenal cortical adenoma, and composite pheochromocytoma. Then immunohistochemistry of pheochromocytomas will be positive for tyrosine hydroxylase, dopamine beta hydroxylase, GATA3, and normal neuroendocrine biomarkers like chromogranin A, synaptophysin, and INSM1. It will be negative for keratins. S100 and SOX10 will be positive in sustentacular cells. If S100 and SOX10 is lost in sustentacular cells, then we can suspect a metastasis. Positive for melan A and SF1, and negative for neuroendocrine markers like chromogranin A. Negative for GATA3 and tyrosine hydroxylase are characteristic for adrenal cortical tumors. So whenever there is pheochromocytoma and paraganglioma syndrome, we have to suspect these 6 clinical syndromes. That is neurofibromatosis 1, MEN2, which includes MEN2A and 2B, VHL disease, renal cell carcinoma with STHP mutation, Carney's triad, and Carney's triticus dyad. Coming to the prognostic scores in pheochromocytoma, most commonly we use the PAS score, in which because of the confluent necrosis, we have given a score of 2. Then all scores were 0, so 2 out of 20 we have given. In this PAS score, if it is crossing more than 4 or more than 4 score, then we can consider it as malignant. If it is less than 4, it is benign. So PAS score is used to differentiate benign from malignancy also. And a GAP score is used to differentiate whether that is well differentiated, moderately differentiated, or poorly differentiated. In our case, the GAP score is 3 out of 10, and it is a moderately differentiated pheochromocytoma. Coming to the pathogenesis involved in pheochromocytoma, primitive cells of the neural crest will mature into pheochromoblast and neuroblast. Tumors arising from the pheochromoblast or mature chromaffin cells turn out to be pheochromocytomas, and from mature sympathetic ganglion cells are neuroblastomas, ganglioneuroblastomma, ganglioneuroma, MPNST, schwannomas, and neurofibromas. When all these tumors, both sympathetic ganglion cells and mature chromaffin cells, when tumors are arising from both cells, then we call it as a composite tumor. Coming to the genetics, the genes most commonly affected in pheochromocytoma take 2 pathways. One is enhancing the growth factor receptor signaling, and one is which increase the hypoxia inducing factor 1 alpha activity. Genes which are involved in growth factor receptor signaling are RET and neurofibromatosis 1, and which involve in hypoxia inducing factor 1 alpha is VHL gene and succinate dehydrogenase X, which includes SDH A, B, C, D, and AF2, and so on. In our case, it is the pathway which involved hypoxia inducing factor 1 alpha. So we have added carbonic anhydrase 9. We can add GLUT1 also, but carbonic anhydrase 9 has more sensitivity and specificity compared to GLUT1, and it turned out to be 95% positive in this case. And in pheochromocytoma, we have genotypic clusters, in which cluster 1 is pseudohypoxia cluster, where tumors with mutations of VHL and SDH genes are involved in this pathway, and our case belongs to this cluster 1. In cluster 2, it is tyrosine kinase cluster, where RET and neurofibromatosis 1 is affected, and cluster 3 is WNT altered pathway, which is also seen in case of sporadic adult pheochromocytoma. And the clinicians has done a genetic mutation studies on VHL gene, which came out to be missense mutation in a VHL gene. These are my references. Thank you.
Then I told today. Close the account, some days only could be open, that time only with them, or else I'm doing so. Usually one is enough, asking to be doing it. So okay, then apply continue பண்ணுங்க. Then after that, Batma is
But it's not muted the phone.
Excuse me.
Valar, ask them to mute Valar. What is this?
Amma,
Not talking. Yeah. Everyone to come and do that's their duty. It's not that I'm doing from first onwards. No, it's not. Together holiday duty. If Sankrantila 2 days, whoever is doing
Dr. Sulochana.
Next person.
One of the participants just
holiday duty assistant.
So, Dr. Syed Mosa, on the IHC picture on the membranous positivity zoning, like, can you just show that, ma?
Yes, ma'am. Yeah, the first image here on the left side is carbonic anhydrase 9.
Oh.
So this marker we have added after getting a history from a clinician that they have done paraganglioma surgery for the neck swelling, which came out to be paraganglioma. Then we thought of syndromes associated with paraganglioma and pheochromocytoma, and added carbonic anhydrase 9, which came out to be positive, ma'am. And after that, clinician has done the mutational studies also, which showed missense mutation in VHL gene.
Okay, ma. Okay, Dr. Mosa. Any questions, madam?
No questions, ma. நல்லா இருந்தது கேஸ் எல்லாமே என்ன இன்னைக்கு MEN
MEN neuroendocrine tumor
போல இருக்கு இல்ல neuroendocrine day.
Okay, Dr. Mosa. Madam Padma. Thank you, madam. Can we go on to the next case? Dr. Abhirami from Apollo. Can you share your screen, please?
Yes, ma'am.
We should ask the participants to mute Dr. Valar. Lot of interference when people are presenting.
Yes,
so
ma'am.
Otherwise, co-host, you can also mute them. If they are not muting, we can mute them. So it becomes little difficult.
Yes, ma'am. Yes, ma'am. We'll do it, ma'am. Yes, ma'am. Sorry, ma'am.
Ma'am, is my screen visible, ma'am?
Yes, ma'am. Dr. Abhirami, you can start.
Yes, ma'am. Good afternoon, one and all. I'm Dr. Abhirami from Apollo Main Hospital, Greaves Road. So today's case is a 18-year-old female who presented with complaints of bulging of right eye, which she noticed 2 months ago, with retroorbital pain and blurring of vision for 2 months. So imaging done here, it showed a extraaxial space occupying lesion which was arising from the right frontal bone and involving the extraconal space of right orbit, and it was also extending into the subarachnoid space over the frontal bone with dural thickening. So since it was a dural based lesion, the radiology, they suggested likely meningioma as the radiological diagnosis. So this is the same lesion that is seen extending into the right orbit. So in MRI, the patient also had multiple nodular lesions in the subcortical white matter also of the bilateral frontal lobes. So since there was some ring enhancement around these lesions, radiologically, they favored an infective etiology such as either tuberculoma or neurocystic sarcosis. And the patient also had a subcutaneous soft tissue lesion over the right frontal bone, and that was suggested as dermoid cyst on MRI. So there were multiple lesions with each lesion that different diagnosis was given on radiology. So since it was compressing the frontal bone, they went ahead with the right frontotemporal orbital zygomaticotomy and with total excision of the lesion. So intraoperatively, the tumor was highly vascular with a soft suckable tumor. The specimens that were sent to us one was the parietal scalp lesion that was a subcutaneous lesion, and the other one was right frontotemporal orbital extradural lesion, which was completely excised and sent to us. So this was the gross of the tumor, which showed a gray-white to gray tan. It was a soft tumor with some hemorrhagic areas on gross. So microscopically, this shows a low power view where we can see some thick, broad fibrous bands, which is separating the tumor into compartments. And the tumor cells are predominantly arranged in a nested pattern. And these nests were separated by thin fibrovascular septa. So again, here it was predominantly in a nested pattern, and this fibrovascular septa was rich in vasculature. In some places, we could make out an alveolar pattern where at the periphery, the cells are clinging to the septa, and at the center, there is some loss of cohesion. And they were forming some cystic spaces at places. So this is the hyper view looking at the cell morphology. The cells had a polygonal cells with abundant eosinophilic granular cytoplasm with eccentric nucleus and a prominent nucleoli. Some areas which showed some hemorrhage and necrosis was there admixed with the tumor. At places we could see this trabecular bone fragments probably from the frontal bone, and this tumor is invading the bone. So here we can see the skin that one of the subcutaneous lesion that was excised and sent, it was showing skin, and this tumor was present in the dermis, and the tumor was showing the same morphology as I described. So based on morphology, we gave an impression of a malignant tumor with epithelioid morphology, and we advised a radiological correlation on IHC for further categorization. So our differential diagnosis, just based on morphology, one was a metastatic renal cell carcinoma, given this nested pattern, and alveolar soft part sarcoma, because at places we could see alveolar pattern with abundant granular cytoplasm and prominent nucleoli. So other DDs were paraganglioma, granular cell tumor, and any metastasis such as adrenocortical carcinoma, metastatic hepatocellular carcinoma. So although the age is very young, 18-year-old female, these are all common in older age groups. Still, because of the morphology, we had all these in mind also, and a less likely possibility of a rhabdoid meningioma. So since we had one of the differential diagnoses as alveolar soft part sarcoma, a PASD stain would help in that. So PASD stain, we didn't find in alveolar soft part sarcoma, it is typical to find PASD positive diastase resistant crystals. In our case, we couldn't find, it was just a faint granular positivity here and there in some of the cells. So we proceeded with the IHC. So we first started with CK and Vimentin. CK was negative, so that ruled out most of the metastatic carcinomas. And MSA desmin myogenin for a skeletal muscle differentiation we had put, and that was also negative. Synaptophysin, since we had a differential of paraganglioma in mind, we had put synaptophysin, and S100 for granular cell tumor. That was also negative. EMA for rhabdoid meningioma, and also for other metastases that we were considering. That was also negative. Paxate, since we had a diagnosis of metastatic renal cell carcinoma, that was negative. So inhibin and melanase for adrenocortical carcinoma and all. So that was negative. Also, melanase ruled out melanoma, and melanase SMA, this combination was put for PCOMA, and that was also negative. So most of our tumors were ruled out except for alveolar soft part sarcoma. So we proceeded with a TFE3 IHC. So that was strong diffuse nuclear positivity. So coming to the list of tumors with TFE3 expression, apart from alveolar soft part sarcoma, there are other tumors that express TFE3. So one is a childhood RCC, that is XP11 translocation RCC. So that we had ruled out because Paxate was negative. Even some granular cell tumors can overexpress TFE3. So that was also ruled out because S100 was negative. And PCOMA with TFE3 rearrangements is known, and that we had ruled out because melanase and SMA was negative. So the other three tumors like epithelioid hemangioendothelioma and SPEN, these are all some rare tumors that can show TFE3. In this case, the morphology did not fit in with these, the last three. So since based on exclusion with only TFE3 being positive and morphology also fitting in, we had concluded with the final diagnosis of alveolar soft part sarcoma, and we did not get a primary site history at that time. So, and rarely it can happen in head and neck also. So we favored query metastatic was our diagnosis. So after going back and retrospectively on probing, the patient gave a history of left thigh mass, painless mass, and an ultrasound done outside that mass was reported as an intramuscular hematoma. Later, following this report, this ultrasound thigh was done here, which revealed a 5 by 5 by 4 centimeter soft tissue mass in the thigh. So we conclude this could be the possible primary for the brain metastasis. The biopsy from this lesion was not done here, only the brain biopsy was done. So we assume this would be the primary for that. Short note on alveolar soft part sarcoma. It was first discovered in 1952. It's a very rare soft tissue tumor, accounting for about 0.5 to 1% of all the soft tissue sarcomas. It's uncertain histogenesis characterized by a specific translocation between chromosome X and 17. And this chromosomal translocation results in a gene fusion called ASPSCR1 TFE3 gene fusion. This fusion gene is responsible for TFE3 overexpression that we see on IHC. Usually it presents in young adults with female preponderance between 20 to 30 years age group. It usually presents as a slow-growing painless mass in the deep soft tissue of extremities. Because of its slow growth and it doesn't produce any pain, it is often overlooked. And it also metastasizes early. So many times it can present initially at a metastatic site. Most common site is lower extremity, thigh, followed by trunk and head and neck, which usually happens in children. And rarely some internal organs, female genital tract like cervix, vagina, and even urinary bladder bone can be involved. So among the soft tissue tumors, alveolar soft part sarcoma is the most common soft tissue tumor that metastasizes to the brain. And it produces both early and delayed metastasis. It can present with metastasis at presentation, or it can present like several years, almost a decade or two after excision, it can present as metastasis. So many times the primary is overlooked. Most common site of metastasis being brain, lung, liver, and bone. So the pathogenesis, because of this ASPSCR TFE3 fusion, there is an increased c-Met overexpression. The c-Met is a tyrosine kinase receptor that is involved in, that promotes cell growth. So crizotinib is a MET inhibitor that can be used as targeted therapy in alveolar soft part sarcoma. Usually grossly it presents as multiple soft fleshy nodules with areas of hemorrhage and necrosis. It is usually a highly vascular lesion because of that septa that contains very thin sinusoidal vessels. It usually presents as a very vascular lesion. The diagnostic criteria, microscopically, we see eosinophilic polygonal cells in an organoid or nested pattern with the septa showing rich sinusoidal capillaries with intracytoplasmic crystals, PASD positive crystals. Of course, in our case, we didn't see. and it is confirmed by TFE3 nuclear expression by IHC. Of course, we have to rule out all other tumors that can express TFE3 IHC that I had already mentioned. So this is the most common differential diagnosis is the RCC, renal cell carcinoma. PASD stain will be of much help because we see diastase resistant crystals in a alveolar soft part. PAS will be positive both in alveolar soft part sarcoma and renal cell carcinoma. So a PAC site will be of help to rule out a renal origin. So prognosis, by definition, it's a high-grade tumor, and the complete wide excision is the most important treatment, followed by adjuvant radio or chemotherapy. So metastasis, it usually has local recurrence if it completely excised, and metastasis can involve lung, liver, bone, and brain, even after 10 years of diagnosis. So we need to repeatedly probe the clinical history if we have this tumor as a differential in mind. So usually the overall survival rate is about 80% and 56% at 5 years. So going back, we found some articles where to know the incidence of this brain metastasis in alveolar soft part sarcoma. So among all the soft tissue sarcomas, alveolar soft part is the most common one that metastasizes to the brain. So in some articles that they studied about 7 years, they could find only 8 patients of alveolar soft part sarcoma with brain metastasis. So that explains the rarity of this case. And moreover, we didn't even have a primary history at the time the biopsy was done. Metastasis is about 11% among all the alveolar soft part sarcoma. Brain metastasis is seen in around 11%. So conclusion, always alveolar soft part sarcoma at metastatic sites is most commonly misdiagnosed as a renal cell carcinoma. Because we don't have a primary history, this alveolar soft part sarcoma is often overlooked. So, and in brain, the metastasis of alveolar soft part sarcoma is commonly mimics meningioma. In multiple articles also, this alveolar soft part sarcoma in brain had been misdiagnosed as meningioma. So it should always be kept in mind in young patients, and especially when we see multiple lesions in brain when that are highly vascular. With the absent renal mass on imaging, we should think of alveolar soft part sarcoma. It is usually confirmed by IHC for TFE3 and FISH for this gene fusion. And not only TFE3, we should use IHC to exclude all other morphologic mimics that I had enlisted before. And having this tumor in mind, there has to be complete wide excision is the most important for improved survival. So giving a preoperative clue to the surgeon will help him to do a complete wide excision. Thank you everyone for the opportunity.
Thank you, Dr. Abhirami.
Yes.
Any questions? So that was a superb presentation. You ruled out everything.
Thank you, ma'am.
How often do you come across alveolar soft part sarcoma?
It's actually very rare, as you already said. Among all the soft tissue, it's about 0.5 to 1%. It presenting as a soft tissue tumor itself is rare, and it's even rare to first present as at a metastatic site, that too brain.
Yeah. Okay,
Yes,
what are the other sites of metastasis you said?
It can be metastasis to lung, liver, bone, and brain, rarely lymph nodes.
Okay, ma. Thank you, ma. That was a well-presented case. Thank you so
Thank
much,
you, ma'am.
Dr. Abhirami and Dr. Team Apollo.
Thank you, ma'am.
We go on to the final presentation, Dr. Banu Kirtana from SRMC.
Very nice, Valer, this case. Typical presentation,
Yes,
properly age presentation, the way she described the differential diagnosis, all was very wonderful presentation. Really
We don't get to see alveolar soft part
appreciate
sarcoma
that.
often, madam.
We have seen during our PG days.
Although that is with metastasis to the brain, which is rare, even more rare.
Yes. As she pointed out, meningioma, we have to think this. as a DD. That's a point. Good point she brought up. Very nice.
Thank you.
Thank you.
madam.
Thank you, Valar.
Thank you, Dr. Abhirami. So we go on to the final presenter, Dr. Banu Kirtana. Please share your
Good
screen.
evening, ma'am. Is my screen visible, ma'am?
Yes, ma. Yes, ma.
Yes. So, good afternoon, one and all present here. So, since mine is the last presentation and I'll not take much of your time. So, here from SRMC, we are presenting a case of 72-year-old female patient who came with the complaints of postmenopausal bleeding for 2 days and was associated with pain and passage of clots. She's postmenopausal for past 26 years. So the clinician found on pervaginal examination a cervical mass that was obstructing the internal os, and it was posterior fornix was full with the mass. On lab investigation showed the patient was anemic, but other parameters were normal. Since there was pervaginal mass, the patient was subjected for radiology and MRI was done. MRI suggested malignant lesion measuring 2.8 by 3.1 by 3 centimeter, occupying the uterine cervix as well as lower uterine body. But the parametrial and the vaginal extension was not seen, and bilateral ovaries were free of tumor and atrophic. So following which, we received a endometrial, endocervical, and ectocervical curating. Altogether, the soft tissue was aggregating to 2 cc. A microscopic histopathological examination showed multiple fragments of tissues that was completely composed of squamoid cells, which had moderate eosinophilic cytoplasm, vesicular to nuclei. We did not see any endometrial tissue in the curating. Though it was sent as endometrial tissue also, we did not see any endometrial tissue. And hence the impression was given as cervical intraepithelial neoplasia grade 3. And adjacent invasive carcinoma can be considered since there was a mass. So following this, the patient was referred to oncologist and she was subjected for surgery. Open radical hysterectomy with right and left pelvic node dissection was done, and we received the gross specimen. So we received a TAH BSO specimen with vaginal cuff margin, weighing 75 grams and measuring 8 by 4.5 by 2.8 centimeter, and the cervical length was 3 centimeter. The cervix showed growth of measuring 3.1 by 2.2 by 1.8 centimeter, and the lesion was involving all the clock position of the cervix, and the lesion was also seen infiltrating the lower uterine segment. Whereas grossly, the vaginal cuff and the parametrial margins were free of tumor. The endometrium showed 2 tiny polyps, but other than that, the fallopian tubes and the ovaries were free grossly. So coming to the microscopic sections, so when we examined the vaginal cuff, there we saw dysplastic areas involving the entire length, but there was no stromal invasion seen in any of the vaginal cuff margin at all. So further, cervix was sectioning was done, and the cervix showed in 3 areas involving the entire length, and the adjacent area of focal invasive malignancy was also noted, formed by strands of squamous cells intervened by desmoplastic stroma containing lymphocytes. The cells were large with moderate eosinophilic cytoplasm, abundant with vesicular chromatin and all that. So since there was a lesion in the cervix, we did IHC for P16 and it turned out to be positive. As I mentioned in the gross, there were 2 polyps in the endometrium. So when we examined the endometrial specimen, we of course saw a benign endometrial polyp, and more bits were studied from the endometrium, which showed a superficial spreading of these dysplastic cells moving along the lining cavity, but we did not see any kind of any kind of invasion into the endometrium. As we can see in this slide, there is a complete movement of cells throughout the lining cavity, whereas we did not see any penetration into the endometrium at all. So the cells were very pleomorphic, similar in morphology to that of seen in SYN3. And this is a higher power view of the same. And when the fallopian tubes were seen, the right fallopian tube was very normal in histology, whereas in the left fallopian tube, we saw the mucosal surface was completely replaced by the tumor cells, which were in similar morphology to that of SYN3, and there was no stromal invasion at all. So these were the findings in the case, and the bilateral ovaries were free of tumor. So now, since there was, though the gross lesion size was around 3.1 by 2.2 by 1.8, here we saw a superficial extension of the tumor into the endometrial cavity and further still extending into the lumen of the left fallopian tube. So as we now see in CAP protocol TNM staging, the staging here mostly talks about the PT2 usually talks about the tumor extending to the lower 1/3 of the vagina or to the pelvic wall. And of course, it confines itself with the measurement 2 to 4 centimeter. And there is no mention about if there is any staging difference for whether we have to put it in any other category if it extends into the endometrium or to the fallopian tube. Hence, we staged based on the size greater than 4 centimeter and we gave it as PT1B3. And with the similar finding, we gave a FIGO staging of 1B3 and the final diagnosis of open radical hysterectomy PT1B3 PN0 FIGO stage 1B3 moderately differentiated SCC associated with HPV. The main highlighting point here we wanted to show is the superficial spread of the in situ component along the endometrial cavity, further involving the fallopian tube. So here we wanted to discuss mainly about the spread of tumor SCC of CA cervix. Usually the SCC cervix spreads through direct local invasion of adjacent tissues and lymphatics or through perineural or perivascular tissue invasion, lateral spread through bony pelvis and encompassing and obstructing one or both the ovaries. And then there is a direct invasion into the uterus, that is into the myometrium through lymphatics. Whereas in this condition, this is very unique because superficially the SCCs are spreading along the endometrial cavity and further reaching the fallopian tube, which is a very, very rare case. And there are only very few cases reports have been found in this condition. The proposed theory for this spread possibly is the squamous metaplasia, which would be the predisposing condition. And this kind of spread is also been recorded to spread along the tubal mucosa, fimbriae and ovary. Most common occurrence is in the older age group. The other proposed theory is either a cervical stenosis because of the lesion and the added pyometra could be the prompting effect for this kind of spread. So we did an extensive survey of literature where the Anisha et al. Has reported 26 cases of carcinoma cervix with endometrial involvement, of which 9 cases showed carcinoma in situ and 3 cases showed tubal involvement. Similarly, Kushima et al. Has also reported 5 cases of superficial spread of SCC along with endometrium and fallopian tube and ovary involvement. So here I would like to, as when I went through the literature, here I came to a proposed molecular mechanism what could be causing this kind of spread, but still the mechanism is not very clearly understood. Here they're talking about the increased CD138 expression. So CD138 is usually normally expressed in normal epithelial cells or including stratified squamous epithelium and in the plasma cells. So the increased expression of CD138 has also been well established in endometrial carcinomas and ovarian carcinomas. But decreased expression of CD138 can be correlated with tumor invasion and progression of cervical carcinomas. So loss of CD138 expression is an early... Pardon me? Loss of CD138 expression is an early event in cervical carcinogenesis. So this molecule is strongly expressed in SYN1 and SYN2, and the expression keeps reducing as the tumor advances. Like in SYN3, the expression is reduced, and furthermore, in microinvasive and invasive SCC, it's still more reduced compared to that of SYN3. So the proposed molecular mechanism here is CD138 expression in carcinoma cells may participate in superficial spreading by regulating cell-to-cell interaction, and by contrast, carcinoma cells that are lacking CD138 expression may become overtly invasive carcinomas. So this is the concept which we got it from this article, Superficial Spreading SCC, report 2 cases with emphasis on molecular mechanism. So how many ever articles we studied, we couldn't find the optimum treatment that can be determined if there is a spread into the endometrial cavity or if it's spreading to the tube. And the prognostic significance is also not been recorded. Even in FIGO system, this staging has not been included, but few articles are proposing that we should give stage more than 1B, higher, it should be higher up to more than 1B. As when we went through AJCC also, we did not find any reference pertaining to this condition. So we thought it is necessary to bring the case to the forum, and we are in the verge of publishing this case also. So these are my reference articles. This is the recent review of FIGO system, where still they didn't mention about any topic or any mention about spread into the endometrial cavity and the fallopian tube or ovary. So thank you for the opportunity. These are my reference articles.
So this case was actually quite intriguing because nowhere we saw that particular tumor. And I mean, it was only superficially spreading all along the endometrial cavity right into the fallopian tube. But it was not invading the stroma anywhere. And as very correctly Banu said, Dr. Banu said, this is not mentioned in the FIGO thing. They talk about vaginal extension, but this was not exactly mentioned in any of the staging thing. And therefore, I think if anybody else has reported, they can also share their experience. Hello.
Oh. Sandhya, anything to do with the ichthyosis uteri?
I am not sure whether the literature has mentioned this, madam, but maybe there could be because I don't know. Banu, did you find anything with connection with ichthyosis uteri?
Because ichthyosis uteri, you find squamous completely squamoid differentiation, right? And it also spreads like a,
Along the
entire.
Yeah, but that's a that's a metaplasia, no, ma'am. Probably, yeah, the metaplasia may turn into. But does that come from the squamous epithelium of the ectocervix, ma'am?
There's dysplasia in this condition, ma'am. There is a pleomorphic cells rather
The
than
cells
the
are all
metaplasia.
very pleomorphic. It is just as if the squamous carcinoma has walked all along the uterine cavity. It's not benign condition. It's not benign at all. All along the whatever she showed, they were all very, very.
That's what I know. Okay.
Yeah. So here, as you see, madam, here, whole thing, and we were very surprised to see this in when the endometrial curate came, there were small bits and pieces of this. So only when we later, when we got the entire specimen, we could see that the whole thing, and nowhere it is going below
Because
that.
you find
It's just
something
all along. Yes. So.
Does ichthyosis uteri turn into squamous cell carcinoma?
Madam? Ellen, madam?
What did you say? Ichthyosis will turn to any history? I mean, any reference there?
Okay, can you repeat the question again, Ellen, madam? I didn't get it.
Ichthyosis cases.
Okay. Yeah, possible, madam. Possible. Anyway, squamous metaplasia, the next thing would be probably dysplasia. Quite possible. But here there was a documented squamous cell carcinoma in the ectocervix. And so it's the same thing tumor, but it is usually it will infiltrate into the uterus. It will infiltrate into the uterine cavity and myometrium. But here it is not infiltrated. It's just walking all along the cavity, along the endometrial cavity, and into the fallopian tube. But even in the fallopian tube, it's not gone into the wall at all. It's still in the epithelium. It is in the mucosa. It is in the epithelium. So that is very, that was quite strange. I mean, we have never reported like this. In Europe, epithelium I have seen, madam, from the spreads like that, without invading the stroma. But here it's first time we are seeing something like this, ma'am.
Quite a rare finding and something very similar to the so-called bronchiolo-alveolar type of lung cancer.
Exactly.
Where it spreads along the wall and without
without invading
the entire architecture. Yeah. So okay.
Oh, thank you.
Lepidic pattern of involvement, Anna Maria, madam.
What pattern?
Lepidic pattern, that's what they call. No,
that is what I meant. So now lepidic pattern சொல்றீங்க. We used to call it bronchiolo-alveolar. That's all. It is spreading along the wall. Yeah, without jeopardizing this main architecture.
Yes.
So without disturbing the uterine, this thing, it is going along the cavity. It is not
yeah. That is, it has not yet acquired the molecular characteristics to invade. That is the interesting part, ma'am. It has not acquired that
Yeah.
molecular
Yeah,
characteristic
that is
to
true.
invade and go into the
Yeah.
stroma.
Okay.
So it is going all
Yeah.
along right up to the ovary, right up to the
Yeah.
fallopian tube. So that's
Okay.
there must be something that is lacking. It's not getting that to get into the stroma.
Yeah.
And that's why she found this paper.
Yeah.
Banu found this paper where CD 138 seems to have some role in that. So which is again
Yeah.
a very interesting paper. We didn't do CD 38 in this case, but maybe that's
Yeah.
that's a proposed theory, a molecular theory.
Yeah. So CD138 is very often used in IVF, ma. Before doing the IVF.
Oh, okay. Yeah, for plasma cells. Yeah, correct.
Infertility cases.
Yes.
Yeah. So in the uterine curettings, they ask for a CD138 score,
yes.
like whether it is positive or yeah. So
So maybe some connection there.
definitely an endometrial. Yeah. Okay. Okay.
Thank you, ma'am.
Again, it's an eye opener.
Yeah, exactly. Thank you, ma'am. Thank you.
Ma'am, thank you, ma'am. Thank you, Dr. Banu. Thank you, Sandhya madam, and thank you, Dr.
Thank
Lee,
you, thank
for
you,
the
ma.
nice presentation. Ma'am, anything else? So we to the any other comments, ma'am? Any other suggestions?
That's stupidity, but
So
They're
then
not presenting all the cases in the city pathology forum. Only few of them have put their cases earlier.
price for desertion is better.
that we'll ensure that they post it, ma'am. Post it. in the
Because
group. Yes, ma'am.
as the Sandhya madam case, if could have been there and
We can.
we
Yes,
could have
ma'am. Yes, ma'am. Well taken, ma'am. Will do. Next time வந்து பாத்துக்கலாம்.
பாருங்க. கொஞ்சம் முன்னாடியே கேளுங்க. Atleast one day before
சொல்லிட்டே தான்
also.
இருக்கு. But
அதான் அவங்க maybe they are working till the end நினைக்கிறேன்.
but at least ஒரு few photographs.
That is
Okay, ma'am. Thank you so much. Thank you, Sita, ma'am.
Thank you, Alice. Thank you so much.
Thank you all the presenters for the wonderful presentation. So
you.
we are close. Thank you so much.
the pyroclastic flow is basically something which is crushed, and once it, sandblasting, which they used to remove paint from a car, like paper. But this is hypoheated particles of sand, and when they come onto your skin, they stick. And so much of there that it created a plaster of him. So eventually it would have been too heavy and too much heat for him to stand.
He died.
You can't run away from it because unless you have like a 4 to 5 hour distance over it now.
Yeah.
That's it, it's over.
It's over.
Yes. When I saw, there was photos that